Good afternoon. Welcome everyone on this beautiful day in the spring. So, we are glad you're inside the building, but hope you'll also get out and enjoy the sun today. Um, on behalf of Cape Cod Healthcare and Emerald Physicians, I would like to welcome you to our Wellness Trails event. My name is Kumara Sidhartha. I am a physician, medical director at Emerald Physicians, Cape Cod Healthcare, and we have been thrilled to offer you this Wellness Trails education event over the past year and a half now, close to a year and a half. And we do a variety of educational topics that covers the spectrum of health, uh, with emphasis on education, preventive efforts, so that you as a patient can understand what are the things you can do to start taking an active role in taking care of your health. And that's kind of the main focus, the education and empowerment piece of this Wellness Trails. And today, we are adding a different flavor to the series we have done. April happens to be the National Healthcare Decisions Month. April 16th is the National Healthcare Decisions Day. And what does it mean for you is, all those decisions that are important for you and your loved ones in regards to your health. And it can be as simple as the decisions, the questions that you need to ask when you go and see your doctor, or you are in an emergency room and you're in a situation just trying to understand what is happening to you in that health situation. What are the things you need to be aware of? What are the options you have in addressing that so that you can make a more informed decision? And it also, and more importantly, it applies to also the future scenarios of how you would want to make decisions, or if you're unable to make those decisions, who would you want to assign to handle those things. So all those important topics we'll discuss today. Cape Cod Healthcare has a fantastic initiative in this regard of the Quality of Life Initiative, and we have the two of the best experts in that topic today to speak about that as well. And there are some snacks we have, and we'll have a small break in between the next two speakers, so that you can go to the restroom at that time and use the snacks. The restrooms are located across the entrance doors to the conference center, when the door that you came through. And I think with that, we'll get started. And I'll speak briefly just to get an understanding of when you go to a medical office to see your doctor, it is important to use the time to get the most effective information exchange so that you can make the best decisions you can about that visit, what's happening during that visit. I've been practicing, this is my 22nd year in practice, 16th year on the Cape, and I've come to realize the amount of information that flows in between the people, the patient, the nurse, and the doctor in the room. It has just increased exponentially in the past decades, right? There is more and more decisions to be made. The tests that we do, the amount of information that we gather about your health, those things have changed as well. So there is just enormous amount of information that is coming up in an office visit. And I think it's important for us to have a framework for you so that you can know what is the most priority there, what kind of information is the most priority at the end of this visit, so that you can know the specifics of what's the gist of that visit that's happening to you, what what are you supposed to do with that information, right? Because it's important to be able to, for you to express what concerns you have, and then the physician, the clinical team, to be able to use that information to assess your health situation during that visit and give you the relevant information so that you can make some choices, some decisions during that visit. Because ultimately, that the efficiency of that communication is going to determine how useful that medical visit is for you, and it also is going to determine your overall experience of that healthcare encounter. This is just the push about healthcare change is now more and more focusing on what is the right thing, which is focusing on the health decisions based on what the patient needs to do, what the patient wants to do. So patient-centered care, as defined by the Institute of Medicine, is providing care that is respectful of and responsive to the individual patient preferences, their needs and values, and ensuring that the patient values guide all the clinical decisions. But in order for us to achieve this goal, I think it's important to make sure that the clinical team understands your concerns, your needs, your preferences, and you need to be able to use that visit to quickly express your needs and gather what the clinical team is telling to you. This is just some basics on where the patient-centered care is centered around. But the key point in the slide is to just show that the components that are having this arrow mark there, all of that depends upon the proper exchange of information between the patient and the clinical team. Without that clarity, none of this can be achieved, right? And there are newer barriers that are coming up in the doctor visit. One of the main barriers that we see nowadays is the electronic medical records, where healthcare systems are required now to not use paper record. We are supposed to use the electronic computer records, and that comes in the way of how the experiences for the patient and the communication. When if I am the physician and you're in the room expressing your concerns, and I'm listening to you, but I also have the responsibility to make sure that it's all documented properly. So I need to deal with, so there is almost like a third person in the room with a computer, right? And so I need to deal with that third person now and then, and during that time, I am disengaging from you, which doesn't leave you with the optimal experience. And so, but it's also it's an essential component we need to deal with in terms of dealing with the electronic documentation. And we are figuring out ways to, there are different ways to address it by having recording it later on using a recorder or using another person to document it, and different ways to do that. But I think these are important barriers to kind of think about. And there is just, as I said, there is just excessive, enormous amount of information that is now we capturing in a patient. There is a shift in how healthcare is being delivered by directions coming from legislation and payers. And so there is more and more data that we in the healthcare system need to capture to show that the delivery of the service is happening with an additional importance for patient experience improving. There is value added to the service. So all of that makes us gather more information, which means there is just excessive information flowing in the offices. So these are barriers we need to think about. And there are some generational attitude differences there depending upon the patient demographic. Um, there are, I come from India, and in India, doctors are next to God, and like anything doctor says, it goes, right? So there is no questioning, there is no dialogue, which is kind of changing slowly now. But it's not more like a partnership, it's more of a didactic communication. Um, but I think what we need to have, and different generations have that phenomenon as well. Um, but I think what's important here is to make sure that when you come for a medical visit, you come with certain framework of asking, what you need to ask, um, and understanding what are your options in that sense. So Ask Me 3 is a very standardized, popular campaign put out by National Patient Safety Foundation. And it is a very simple framework with just 3 questions that sums up what you need to capture with regard to information in an office visit. So at the end of the visit, you want to make sure that you ask the clinical team, whether it is the nurse or the doctor or the nurse practitioner or the physician assistant, that what is my main problem? And you want to make sure that a summary can be given by that clinical team member as to, because by that time you have heard like 15 different points in this test results and what are the complications. And at the end, you want to make sure you get the gist of that. Ask that question. You need to understand what you need to do about it. So whether it is a prescription, whether it is a lifestyle change they're recommending, whether it is a referral to a specialist, again, you want to ask and find out that. And then you need to kind of understand why is it important for you to do that. In other words, what happens if I don't do it? What happens if I delay that? And why is it important for me to do? I think all of that is important. So, there are many other ways to approach this, that I find this to be a very useful tool, and I think this is the central message in my presentation. In your handout, you will have a flyer from that foundation. Simply having this handy and just even getting into the practice of asking that when you go to any clinical encounter, whether it is in an urgent care, whether it is in your primary care doctor's office, whether it is in the emergency room, I think understanding what's happening to you with a very simple framework like this is going to be very useful, I think. This is really about healthcare decisions within the medical setting. But there are so many decisions that you make outside once you leave the healthcare building, right? Whether it is the emergency room, whether it is the primary care doctor's office. Once you leave the building, there are so many decisions we make that influences our health. Whether it is lifestyle decisions, what we choose to eat, where we choose to live, or it could be decisions about how you want to handle your health outcomes in the future. And if you're unable to decide that, who do you think it will be the best person for you, and have we done all those documentation properly? So those are the topics we'll touch upon in the ensuing talks. To take a deeper dive into that, next up we have Dr. Donald Guadagnoli. Dr. Guadagnoli is a Senior Vice President and Chief Medical Officer for Cape Cod Healthcare. Additionally, he is the UMass Medical School Associate Dean for Medical Education at Cape Cod Healthcare. Dr. Guadagnoli received his medical degree from George Washington University and completed his residency at Brown University. A Rhode Island native, Dr. Guadagnoli is a OBGYN gynecologist by training, and was in private practice for many years before working on the managed care side of medicine. And today, he will discuss the importance of advanced care planning. If there is a doctor on Cape Cod who knows all the important elements of it, it is Dr. Guadagnoli. So, we are so appreciative that he was able to make time for this today on a Sunday. So, without further ado, Dr. Guadagnoli. Yeah.
Thank you.
Thanks so much.
I tend to pace, so I don't want to pace and fall off anything. So as Dr. Sidhartha said, and by the way, thank you all for coming today. I was driving here thinking, the most beautiful day we've had in 6 months. And you know, whether it's groups like this or physician continuing medical education that you're doing, one of the things you always worry about is anybody going to show up? So thank you all so much for coming today. It's a testament to what Dr. Sidhartha and Julie obviously have been putting together over the months here, that people find high value in this and are coming to these, and we really appreciate it, and Cape Cod Healthcare really appreciates the great effort on their part to help educate the community. So as Dr. Sidhartha said, I need my sheet. As Dr. Sidhartha said, the Charlie sheet? You don't have it, okay. We've been involved in an effort now for actually about 2.5 or 3 years. And that effort started probably a year or two after I got to Cape Cod Healthcare. I'm an OBGYN by training, and when I practiced, I didn't deal with any end-of-life issues in reality, because my focus was mostly on obstetrics. It wasn't really on the GYN side of it all that much. And as I journeyed back and got to Cape Cod Healthcare in 2012, I began to see on the floors how medicine had changed so significantly since the late 70s and early 80s, when I went to medical school and when I started in my residency. And one of the things that is so different now is how much we can do for people and how long people are living. And one of the things that I saw on the floors that really was striking to me was how often I would see frontline clinical people, doctors and nurses, with tears in their eyes, because they didn't feel like they were doing something for someone. They felt like they were doing something to someone. And their question was, if people want to have this done, we're fine with it. But do they really understand where it's coming from? Do they really understand the ramifications? And is it really something they would want done for themselves? Because quite often what they were thinking was, you know, if it were me, I'm not sure I would want to have this done to me or for me. If it were my parent, I'm not sure I'd want that to be done to me. And so what we decided to do initially was get a group of folks together and try and figure out how we could alert the community to the issue. So we started out with a summit that we had in October of 2015. And during that summit, we kicked it off by me reading a couple of paragraphs from a story about Charlie. It was written by an orthopedic surgeon. It appeared in the Wall Street Journal in 2012. And he talked about Charlie, who was also an orthopedic surgeon and a mentor of his. Charlie developed pancreatic cancer. When he developed pancreatic cancer, or when he found that he had pancreatic cancer, he went to a friend of his who was a surgeon, actually a remarkable surgeon who specialized in this area, who operated and explored him, confirmed the diagnosis, and then said, okay, what do we want to do next here? Because the surgeon actually who operated on Charlie was somebody who had developed a procedure that could increase the odds of his 5-year survival from about 5% to about 15%, but not necessarily with the greatest of quality. And Charlie really had none of that. What he did after he confirmed his diagnosis was he closed his office. He never set foot in a hospital again. He's focused on friends and family and doing what was important to him and spending time with the people he felt were important to him, and died a few months later with no chemotherapy, no radiation therapy, no surgery, nothing that really had any impact on his quality in a negative way. And the story then goes on to say that it's not really fair. Doctors pretty much know everything that's available to them and know how to get the best of medical care, but they also know what the end parameters are. They also know what the downsides are. And so they often will choose not to go a heroic route and rather to focus on friends and family and spend time with them. And then probably the last paragraph that I would read talks about how doctors also don't want the last thing that they remember as they're exiting the world is somebody pushing down on the chest and breaking all their ribs, which is actually what happens when you do CPR on someone. And one of the problems that we have is people tend to get their information from television shows. And on television, 75% of the people who have cardiopulmonary resuscitation survive it and are out on the golf course the next week and having a good time, and everybody looks wonderful. That doesn't even happen if you're 40 and you have a heart attack. The recovery period is significantly longer than that, but that's what it looks like on TV, and 67% of the patients that have CPR on TV actually make it home. The reality is that if you're 70 to 80, there's a 19% survival for CPR. If you're 80 to 90, there's a 12 to 15% survival, and over 90, there's less than a 12% survival, and survival is just that. It's not necessarily being home. It may be being tied to a ventilator. It may be being confined to a nursing home. But it's not what people see on TV. And I guess you can't pace too far. There we go. And it's not necessarily what folks expect. So one of the things that we've come to now, I look out on the room, and I'm willing to bet that most of people in the room remember Marcus Welby. And for the few who don't remember Marcus Welby, you're probably young enough to Google it. So Marcus Welby, well, as I said, everybody remembers Marcus Welby. What people tend not to remember is that Marcus Welby was on from 69 to 74 or 76 at a time when we didn't have ultrasound, MRI, PET scans, CT scans, stenting. When you came into the hospital with a heart attack, we weren't putting a stent in because we hadn't started doing that yet. We were giving you an aspirin and holding your hand and saying sometime in the next 3 or 4 weeks we should figure out exactly how functional you'll be moving forward. Most cancers were death sentences. They were not the chronic illnesses that we've turned many cancers into now. The world has changed substantially, and Marcus Welby can't exist anymore because the science of medicine has advanced us very, very significantly forward. For the folks in the room who don't know, by the way, Marcus Welby was basically a family practitioner. He took care of you at home, he took care of you in the office, he took care of you in the hospital. So he was the model of medicine where you had a doctor that was following you through the different stages that you were going through in your health care. And it's something that I talk to patients about on a regular basis in the hospital now because they really miss Marcus Welby, and they wish that he still existed, and they can't figure out why their doctor isn't coming to the hospital anymore. And the reason for that is basically because the science has gotten so much better. You need to be an expert in the place that you are an expert. So the primary care physicians are experts in primary care and in office-based medicine. Our hospitalists are experts in internal medicine on the inpatient side. And then we've even subdivided further. We've got gastroenterologists and cardiologists, et cetera, that are even more subdivided. And that's a good thing. What's a bad thing is that Marcus Welby was also an expert at shepherding a patient and their family through an episode of illness. He was a familiar face in a strange environment that was immediately trusted and known, and when he said to you, this doesn't look good, we're probably not going to have a good outcome, you were comfortable with that because he was that familiar face, because you had had that relationship over the years. What we're faced with now is when patients come in, they're seeing almost nothing but strangers. And we have to rapidly develop that relationship. And it's changed the dynamic. Because what happens now is patients come in with their families, and what we deal with is families who are saying, oh, you don't know my dad. He may be 90, but he was playing golf last week, with the clear implication then, you should be able to make him be able to play golf next week. And that puts us behind the 8 ball. And that's why we wanted to start this effort. The communication that needs to occur within families is becoming more and more critical as time goes on, because we don't have that trusted figure that we're working with, because people mistrust us when we say, I understand your dad was playing golf last week, but he's still 90. And there are some things that we can't fix as time goes on. Now, the interesting thing is we all know that. As we age, we adapt as we're moving along. Our families may not notice it. Our families probably don't perceive 90% of it. My kids, I'm sure, don't notice that when I go up and down the stairs now, I don't run up and down the stairs, I walk. And when I walk up and down the stairs, I hold the rail. I am afraid of falling. I haven't fallen, and I don't want to. I bought a new car a year and a half ago. I'm sure my kids, I know my kids, thought, well, that's Dad. He buys a new car every couple of years. So, of course, he's buying a new car again. Not quite. My parents actually had started down the journey of the last few months and years of their lives at that point. And I began driving back and forth to Rhode Island on a more frequent basis. I start my day between 7:15 and 7 o'clock in the morning. And if I'm lucky enough to be out by 5, that'll be the day that I pick to try and drive to Rhode Island. I was driving to Rhode Island, and by the time I hit Wareham or New Bedford, was really pretty tired and was beginning to fade a little bit. I bought a new car because it had dynamic cruise control, it had assisted braking, it had lane assist, it kept me safe. My kids think I bought a new car because that's what Dad does. Without the discussions in the families, that's the perceptions our children have of us. Well, he may be 90, but you can fix him. Now, when you have the discussions with patients, and I've had discussions with a lot of patients in the hospital, they say, you know, I'm 88, I've lived a good life. What's important to me is being able to spend time with my grandchildren. If I'm going to end up confined to a skilled facility someplace, that's not what I want. That's not life for me. I don't want to have that. The problem is telling me that is a great discussion, but the family needs to understand that too. What we saw when we started looking at who actually shares this information is that 64% of physicians had completed an advance directive and had shared it with their families. Only 20% of the general public had done that, though. Why is it important for our portion of the general public? Because we have a disproportionate portion of the general public that's over age 65. Here on Cape Cod, over 27% of us are over the age of 65. That's almost double both the state and the national average. It's disproportionately important to us, and it's disproportionately important to Cape Cod healthcare for that reason. And the services that we focus on at Cape Cod Healthcare are designed around that population. As an obstetrician, I would love us to have a neonatal intensive care unit. We'll probably never have a neonatal intensive care unit. There is no reason. We've got a stable 1,200 deliveries a year between our two facilities. It wouldn't make any sense. What do we focus on? Cardiac services. Dr. Zellman, our interventional cardiologist, is one of the best in the country. Drs. Pirandini and Loberman, our cardiac surgeons, are among the best in the country. both of them having been recognized for that, actually. So cardiac services are important to us, oncology services, orthopedic services, neurosurgery, and neurologic services, primary care services, as well as inpatient hospitalists. That's where we focus because we know that our demographic is such that that's where we need to focus. And our population has what we in medicine call comorbidities. Comorbidities is a fancy way of saying you've got extra stuff wrong with you besides whatever it is you came in with. You came in with chest pain and you were having a heart attack, but you also have diabetes. You came in for an exacerbation of your lung disease, but you also have congestive heart failure. And when it gets to physical, identifiable issues like that, most people focus on, yes, those are things that decrease my ability to bounce. A lot of times what people don't think about is the dementia and cognitive decline, the functional limitations and frailties, and how they actually play into prognostically how you are going to do coming back from an event. So 80% of the people, if you survey folks in Massachusetts, we're part of the Massachusetts Coalition for Serious Illness Care, and 80% of folks say, if I have something happen to me that's going, please don't do anything that will impact the quality of my life just to keep me alive. Now, 14% of the people say, pull out all the stops, do whatever. The problem we have isn't with either of the groups. The problem we have is patients and families aren't all on the same page as to which group you fall into. We will do whatever you want. We are happy to do whatever you want. We've been doing these talks for quite a while now and have gotten a lot of stories out of them. And, you know, if you are the 88-year-old lady who says, you know, I've been teaching piano for 50 years now, and if I'm not going to be able to teach piano, don't do anything heroic, okay. We were very grateful the son was able to tell us that because we knew what direction to go. There were also people who've promised a parent through a fence at Auschwitz that they would do everything they possibly could to stay alive. That's our obligation too. The problem is when we don't know which category you fall into. So, as I said, I've been going through this journey myself now too with my own parents. And I've discovered several things as we've gone through this journey that I think are helpful and help people to understand why this is so important. So 3 years ago, at this time, Mom and Dad were living independently at home. The main reason Mom was living independently at home was because Dad was basically her constant caregiver with occasional respite care. Then in the summer, Dad developed pneumonia at the age of 87. And when he developed the pneumonia, it impacted his memory some, and it made it so that he was never able to recover to the point of being able to be independent again. And at that point, we moved them into assisted living. And had very pointed discussions with them, what's important, you know, what parameters are there around what you want and what you don't want. Dad was actually still, at that point, good enough that he was able to really give clarity to it for us, as was Mom. And so when I got the call from Mom about 3 months later that Dad had fallen in the bathroom, my first thing I said was, did you push the button? And she had pushed the button, and very soon thereafter, the folks showed up with a stretcher. But what had happened was Dad hadn't fallen in the bathroom. Dad had had a stroke. And at that point, his memory really began to not be what it was. Now, the other thing that happened when Dad developed pneumonia was he became what's called pancytopenic. So that means his red count, his white count, and his platelet count all got low. And be honest, not an area of medicine I'm real comfortable with, but I know a real smart internist who I spend a lot of time with and was talking to as this was happening. And I said, what do you think? And he said, well, first of all, you need to give him at least 6 weeks after the insult before you make any judgments about memory and about mentation, because anytime somebody gets knocked off their game at 87, it can take a while to get back and see where we're going to be. And as far as the blood counts being low, that could be from the pneumonia. So with the pneumonia, we decided to just kind of wait for the blood counts. When he got hospitalized with the stroke, they came back at me with, you know, we really need to do a bone marrow biopsy on your father. And I said, why? And they said, well, so we can get a diagnosis. And I said, why? And they said, well, because we need to know what's. And I said, we're not going to do chemotherapy. We're not going to do radiation therapy for anything. Am I curious why his counts are low? Sure. Is he going to remember? When we do bone marrow biopsies, the last one I did was as an intern, so it was decades ago. You take a large bore needle and you push it into someone's hip bone. And you take the marrow out, and that bone marrow is what's responsible for making all those blood counts. So that's why you look at it. It's extremely painful. We're better at it now than we were decades ago when I was doing it, but it's still extremely painful. So I said, and as you're putting the needle in, even if we've explained it to him multiple times, he's not going to remember why you're causing him that pain. What are we going to do with the information? And they said, you got a point. As Mom started to bounce, not too long after that, we got them actually both to my aunt's house for Christmas, which was nice. And then Mom, who had congestive heart failure, started to do some bouncing. So for anybody in the room that has congestive heart failure themselves or has a relative with congestive heart failure, just a little fun fact about congestive heart failure. Once you get hospitalized with CHF, you have a 50% chance of survival at 5 years. If you don't take care of yourself, you can rapidly get to a 15% survival at 5 years with a second admission. Taking care of yourself has changed substantially since I was an intern. When I was an intern, we would take someone with congestive heart failure, we would diurese them, get the extra fluid off, and then we'd send them home and say, now don't eat salt, it's your enemy, take your medication, you should be fine. We'd send them home on Good Friday. They would very dutifully not put salt on their ham or canned peas on Easter Sunday, nor would they add it to the canned soup that they were eating, and by Tuesday they'd be back in the hospital again. Recognizing that, we now actually have a congestive heart failure clinic, and we bring a nurse practitioner in before you're discharged to do some education. We bring a nutritionist in after you're discharged to have some education. We have a pharmacist that can come out to your house. So we're doing a whole bunch more to make you cognizant of that. But it's still your right and your ability to say, well, this is what's important to me. Unfortunately, to Mom, what was important was that she be able to add ham to her grilled cheese sandwich at assisted living, and assisted livings do nothing to control diets, unfortunately. Eat corned beef and cabbage when they had it. And so she was one of the folks who deteriorated more quickly than she needed to. However, it was what she wanted. And as she started to bounce in and out of the hospital, I got a call from a gastroenterologist because her red blood count was low, who said, we need to do an endoscopy on your mom. And I said, okay, why? And he said, well, she could have a bleeding ulcer, and I could cauterize it or clip it, and it will help stop the bleeding. I said, okay, that makes sense. So she had that done, and then about 2 days later, he called me and he said, you know, your mother needs a colonoscopy sometime in the next 6 to 8 weeks. And I said, okay. Now, retrospectively, this was 4 weeks before she actually died. I said, okay, help me understand why she could need a colonoscopy. And he said, well, because she had a CAT scan, and on the CAT scan, we saw diverticular disease. And sometimes when you see that on a CAT scan, it can be hiding a mass. And if she has a mass, we need to know about it. And I said, why? She's not a candidate for chemotherapy or radiation therapy. No surgeon in his right mind that I know of would take her to an operating room. And if you do a colonoscopy on her, you may perforate her colon, which will be a life-ending move. What are we going to learn that will be useful? And he said, you have a point. My point is, you don't have to be a physician, a nurse, or anyone clinically trained to ask those questions. You can be my son, the lawyer, instead of my son, the doctor, asking those questions. You can be my son, the accountant. You can be my daughter, the CEO of a bank. What you have to be thinking about is this consistent with what mom or dad wants? Is this consistent with what is going to get them to where they want to be? Or is this something that isn't consistent with that? And we'll tell you if you ask. I don't fault the folks who are asking me to do these procedures, because basically I am quite sure that they deal with the same thing in Rhode Island that we deal with here. And that's children who expect that because of what they've seen on TV and because of how well mom and dad have been doing, that when they get knocked off, we should be able to fix them. And the lack of a recognition that pneumonia in an 85-year-old is very, very different than pneumonia in a 35-year-old or in a 15-year-old. So I can't fault the physicians. They're reacting to what I'm used to is, how are you going to fix this? Not, why are you doing this? That's why we need to get those questions asked. And it's not just at end of life. It's not just here at phase 3 and phase 4 that we need to be doing that. Really, this is something that begins from the beginning of life on. And this is one of the places that we've gone as a group, as we've managed this effort, is to say, you know, the best time to start these discussions in families is at a point in time where it's a pretty benign discussion in the family. And the reality is, everyone who is over the age of 18 needs to have somebody knowledgeable to speak on their behalf if they can't speak for themselves. Because as anybody in the room who's written a college tuition check knows, when your kid goes to college and you send the checks to the college, they're very willing to accept the checks, but they're not going to give you the grades. They're an adult now. So you're not entitled to those grades unless your adult child is willing to share them with you. They're also an adult when they come into healthcare. And as I think most of us know, having raised kids, that, you know, if you get an 18, 19, 20-year-old who gets themselves into trouble medically, the first thing they do is regress to a certain degree. The second thing they do is turn to mom and dad to say, help. So it's a logical thing. It's probably not a pointed conversation, and it wasn't. A couple of years ago, we had the conversation with our family at Easter dinner. My wife and I had it with our 21 and 25-year-old daughters. We said, you know, we need to have healthcare agents identified. We need to have these in our electronic record at Cape Cod Hospital, because we're all living here, and this is the hospital that we may very well end up in. So we need to think about this. We need to think about who the agent's going to be, and we need everybody to understand what's important to us, so that, you know, if something bad should happen, we know where we're starting from and where we're going to as a baseline. It was an extremely benign conversation. The biggest problem that we had was in getting two witnesses who were not listed on the proxy forms to sign them. We had to wait until one of the kids had friends come over so that we could get the signatures witnessed. But it introduces it at a time that's benign in a family. It introduces it as an okay conversation to have in a family. And it also allows you as a parent to make sure that you spend the time helping your child understand, and it changes. Right now, my wife and I are listed as the agents for the kids. I am bound and determined to have grandchildren, so at some point they're going to be getting married. And at that point in time, one of the things they need to figure out is this still the appropriate person as my agent? It may not be. It may be that they want their spouse. It may be that the spouse is the last person in the world that they want. It can be very, very difficult. Being a healthcare agent is a difficult thing. Making the decision to put mom on hospice was not an easy or benign decision to make. You need the support from the family when you make that decision. They need to be sitting there saying, yeah, you did the right thing. That's why it's so important to have everybody on the same page. But, and sometimes spouses are good at that, sometimes they aren't. My older daughter's a nurse now. The younger one may want her as her agent. So it changes, but it gives you the opportunity to introduce it changes over time. One of the things that's most disturbing is that when you survey people, you find that when people have gone through this process, only 10% have actually clued in both their provider and their agent. 62% haven't talked to either one of them. We have called people from the emergency room and said, we have Joe here in the emergency room, and we've got a healthcare proxy form that lists you as their agent. We need to talk to you about what you think Joe would want, and gotten the answer, Joe lives next door to me. I didn't know he put me down as a healthcare agent. That's why our focus is on the conversation within families, between families, with friends, and not so much on the proxy form. Yes, we want proxy forms. Tina, who's talking next, her job, we moved her within Cape Cod Healthcare from being a hospice and palliative care nurse to being our quality of life care planning nurse. Her job and responsibility is to have over 200,000 healthcare proxy forms in our electronic medical record within the next 5 years, because we want to know who to talk to. The forms aren't the issue, though. The forms are the result of the conversation occurring and the agent being identified and people being on the same page. And what we know is that people have the wrong impression. We've gone through samples from our cardiovascular center, Emerald, from the VNA. 78% of patients who report that they have a healthcare proxy form within our electronic record are wrong. They do not. And there are a lot of assumptions that people make. There are a lot of places that these forms get kept. And that's why, actually, as we started down this path, we involved a lot of different folks, including folks who are in, who are in legal and estate planning, who are in financial services, who are within churches and community services, because a lot of the folks will have the forms filled out and then they end up in a safe deposit box, or they end up someplace where they're not particularly useful for a hospital at 3 o'clock in the morning. It's great to bring it to your primary care provider, but don't assume that the electronic records talk to each other, because they don't at this point. They will, hopefully, within the next 10 years, but they do not at this point. What you need to know is, has my primary care provider sent it to Cape Cod Hospital or Falmouth Hospital? It doesn't matter. They're both, the two hospitals are on the same record, so whichever one it comes into, we can enter it into the record. But don't assume that it's in there. Ask. And if you do it at home, you can walk into either of our hospitals, walk in the front door and ask them where the medical records desk is. It's near the front door at both hospitals, and they will scan it in for you. So the quality of life initiative that we put together has really evolved over the years. And what we did, we started out with a task force that came out of that original summit. We also had a steering committee. And we kind of evolved to focusing on the agent and the proxy. There are other forms that Tina's going to talk about. There's a form called a MOLST form, which is Massachusetts Orders for Life-Sustaining Treatment. That's a form where you could actually designate whether or not you want to be resuscitated. That's a form that's really pretty hard to fill out if you're younger than probably 85 and relatively healthy and not with an advancing or an advancing significant illness. Same thing with a care measures only form. It's a form that it's a doctor's order form that says, don't resuscitate me. I want to be kept comfortable only. But it's a very difficult form. And really, we don't want the discussions only occurring with very elderly parents, because they really need to be family discussions, as I hope most of you believe at this point, family discussions that happen recurrently within a family from the age of 18 on. That's where we are at this point, and that's actually one of the asks from this session, is we have now trained people to facilitate these discussions. We've got people trained to go into, because my goal is to have somebody in every church, synagogue, library, senior center, assisted living facility, any place where we can get together with 5 or 10 people and just help facilitate the conversation and the thinking of what's important to me, so that I've thought it through myself and then I've communicated it with my family. That's where we are in the process now. We've got people trained, we've got people who are willing to do that. We've put together toolkits to help guide people through that, which I assume all of you have in front of you. That's the shiny Cape Cod Healthcare Toolkit. Yep, thank you. And this has within it a copy of a healthcare proxy form. It also has basically a living will kind of document in it, as well as questions to ask your doctor toward the end of it. We've done this consistently, and our physicians know of the document. We also have been doing continuing medical education for the physicians too, to bring the physicians through on this too and help them to understand that, you know, focusing on an organ system and how you're going to fix it isn't necessarily focusing on the patient and what's important to the patient. So it's been a multi-dimensional effort that we've had. But not only would we ask that everyone here go through and think through the toolkit and fill out the toolkit, but we'd also ask if you have any groups that you can help us have access to. We can bring in the facilitators to facilitate the discussions. And it's an important thing for us to do across the Cape, because it is an awful feeling for both patients and families to be in the hospital with nobody knowing what mom or dad really wanted, as we keep going down the road and going down the road, and all of a sudden mom is on a ventilator, she's got a feeding tube placed, and everybody's wondering, is this really what she would have wanted? She's not going to recover from this. And the other thing that I'll share with you is there's probably no better gift to give to families than the information about this. You know, we spend the first 20 or so years of our kids' lives telling them they need to get along with each other, that they should be each other's best friends, they will be the resources for each other going through life. Then set them up for failure by having 4 children who have 3 different ideas of what mom would have wanted at the point in time that mom clearly isn't going to survive, and have them start fighting with each other and potentially not talk to each other going forward. When mom died, my brother, who's a lawyer and who handles the legal and the financial side of it and all that, so we've divided and conquered, my brother turned to me after she died and he said, well, you know, at least we know we did what she wanted. She didn't want to die in a nursing home. We got her back into the apartment with Dad. We brought hospice in so that she was comfortable, so that Dad could be supported. And we were able to get her to where she wanted. And fortunately, for Dad's sake, his memory was such that he still has difficulty remembering where she is and that she isn't here. So this is the effort that we've put together. We've purloined mercilessly and shamelessly from other people who have been more than willing to share this, because the group that works on this is willing to share with anybody the efforts that are put together here. And, you know, the bottom line is we're all on the same journey. We're all going to end up the same way. And wouldn't it be nice if all of us can have, from what I understand, from what was publicly reported, the very peaceful and loving exit that Barbara Bush had, because she clearly and obviously had thought this through, because clearly and obviously the family had had these discussions. And when she got to the point with her congestive heart failure where there was nothing to really make it better, she said, keep me comfortable. And that we can do. We can't always do that to the degree that we'd like to, especially with some of the cancers and invasive things. But with congestive heart failure, with chronic obstructive pulmonary disease, with many of the diseases, we can keep you comfortable if that's where you choose to be and what you choose for yourself. There we go. And that's it. Oh, okay. Does anybody have any questions? Yes, ma'am.
You mentioned a care measures only form and also some, I missed it, MOS or something?
MOLTS, Massachusetts Orders for Life-Sustaining Treatment, is actually a physician's order form. And it goes through, do you want to be resuscitated? Do you want to be intubated, transported to a hospital? Do you want to have dialysis? Do you want to have IV therapy? That form you do need to talk through with a physician for two reasons. One, because it's actually a physician's order form. So just so people understand, a healthcare proxy is only of value in a hospital setting or in an office setting. Only a physician can say that you can't speak for yourself and that the person you've designated on your proxy form needs to speak for you. So if rescue comes to the house and you're your spouse's proxy, rescue, if your spouse is warm, is going to resuscitate them unless there's a MOLTS form, which is a doctor's order form, or a care measures only form. Those are the only two things that a rescue can pay attention to that say, don't resuscitate me. Other than that, they're under the obligation that if you've called, then there's an obligation for them to act on that.
And the care measures only form is a publicly available?
Care measures only form is also an order form.
Could you repeat the question, please?
Oh, is the care measures only form publicly available? A care measures only form is also a doctor's order form. You'd need to get it from your primary care doc.
The proxies that you have for the Cape Cod Hospital in Falmouth, now what if something happens and you're shipped out to Boston hospitals? Will you have it in place that maybe Boston hospitals will get a proxy or any of our health information?
That narrow circumstance is actually reasonably easy. If people have accessed us and we're transferring them, we have the ability to transfer the information with them. The problem is if you're in Boston and you have a problem, we don't necessarily, there isn't a connection between the two. But the other thing actually that brings up is the reality, which is, you know, when we're at the front line and we've got mom who's had a stroke, and we turn to the family, generally we're turning to the family to say, what would you think? If the entire family says, well, this is what mom wanted, and this is what mom would not want, and everybody is in concert, we don't really have a huge problem. Because we're going to use common sense and we're going to go with the flow with the family. where we end up needing the proxy and needing the form and clearly identifying that person is when there's controversy and when we can't get a hold of that. So generally, if you show up in any hospital after a heart attack, and if you haven't done well, you weren't witnessed, you didn't get CPR immediately, and you end up in an intensive care unit and you're on drips and we're barely keeping you going, if the people who, if your loved ones who are there with you give us a consistent message, doctors are pretty much going to go with that message and work with that. So.
The presentation was marvelous, thank you, and
Thank you.
beautifully done.
Thank you.
I want to put a little more emphasis on the importance of having these conversations with our children so that they fill out the form that lets us take care of them should that need arise. I've gone through that. The forms didn't exist, but at least I'd had the conversations, so I knew what he wanted and I could do it. But without those conversations, I would have been in deep poo.
Yeah, and unfortunately, we see that too frequently in the inpatient environment.
Are EMTs trained on Cape Cod to check, say, the refrigerator door for a MOST form or any other kind of form?
Yeah, and that's an interesting, one of the groups we brought into the steering committee actually was interpreter services, as we, and yes, EMTs will look, they're not going to search your house. I mean, they're going to attend to the patient, but on the way in the door, they'll be looking on the refrigerator. If you're in the bedroom, they'll look on the nightstand. If your spouse says, here, this is their form, they'll be able to honor that. One of the things that we learned, we've got a fairly significant Brazilian population here on Cape Cod, and apparently in the Brazilian population, you don't put things on your refrigerator. So we're handing out all these magnets and things to put these on refrigerators and training EMTs to look on refrigerators, and all of a sudden we stumbled into, well, that was rather culturally off of you, but yes, I mean, they will look. The problem that you have to remember is that they are an extraordinarily heavily regulated group. They have very, very few options. And if your MOLST form is not filled out properly, they also cannot pay attention to it. And actually, they brought to us, and we did some teaching with skilled nursing facilities. Some of the skilled nursing facilities had a requirement that the form get filled out. And again, it's not about the form, it's about the discussion and the thought process. And so they were forcing the forms to be filled out, and EMTs were seeing things like a form that said, resuscitate me, but don't transport me to the hospital and don't intubate me. Well, for anybody in the room that's done CPR, it's ABC, airway is the first part of it, so we're gonna intubate you if we're gonna resuscitate you. Those two things kind of go together hand in glove. And by the way, if they're resuscitating you, they're under an obligation to transport you to the hospital. It's not, you know, so again, the form needs to be filled out properly. It needs to be signed in the appropriate place by a physician. In the studies that we've done, the reason I'm emphasizing that is because we found them inappropriately filled out, inappropriately assigned different places. Okay.
Hello?
Oh, okay,
Two questions.
sure.
We have a healthcare proxy. How do we know it's on file at Cape Cod Hospital? And this I'm not too sure about. And the second question is, I'm with Emerald, and I've got patient portals from 6 different doctors. Are all of those, do they all go to?
They're not connected.
They're not connected.
Probably not connected. One of the things that happened around the end of the Bush administration and into the Obama administration was all of a sudden everybody started pushing to have us use electronic records. The one thing the government didn't do, which would have been the most useful thing they could do, was require that they all be interoperable. Instead, what happened is everybody who developed an electronic record decided they wanted theirs to be the one standalone that everybody was going to use, and none of them talked to each other. We're in the process of narrowing. This isn't a healthcare reform talk, but as we're employing more and more physicians as a result of things that have gone on, we are narrowing the scope of what's being used. We're training the PCPs to send into us. Unfortunately, probably the only way to know whether or not it's in our record is if you want to give me a call. I'll actually look it up for you. And we can see whether or not it's in there. But the most reliable way is for you to take the proxy into the hospital, to the medical records desk, and have them scan it in, or bring it to your PCP's office and ask them directly to put it into our electronic record. Yes, ma'am.
I wonder, excuse me, I wonder who I would call if I wanted to set up a seminar in my community.
That's what Tina's here for. The next speaker.
Okay. And the other thing I
because-
wondered about is why, if a doctor's signature is required on your form, why is not the agent's that you've selected required?
The doctor's signature is not required on the healthcare proxy form. The healthcare proxy form is not a medical order. So that it is you identifying that you've said Julie is your healthcare agent. You don't need a physician for that.
Oh,
And that's why I said for ours at home, we had to wait until the kids had friends over, because what you need for that is two people who aren't already noted on the form. You can't have, my kids couldn't be the witness for us, and we couldn't be the witness for them because we were each listed on the form. So,
I missed that.
yeah, oh, it's fine. It's fine. And we'd be happy to set up seminars. So.
I'm wondering if you can talk about the 5 wishes. Inside the cover, it says that it's legal in Massachusetts, but I heard that it is not.
Yeah, that's why we don't use it.
You don't use it.
It gives people the inappropriate impression that it's a legal document in Massachusetts. It is not a legal document in Massachusetts. And that's actually, because it's a good form. There's nothing wrong with 5 wishes. Our document is not terribly different from the 5 wishes. It's just got a little bit better clarity as to what's legally and not legally binding. The other thing that you need to realize is that living wills, which is basically what the 5 wishes is guiding you through, as well as the second portion of this, that also is not legally binding. And part of the reason it's not legally binding is because you always have the right to change your mind. And so, that's why you need to keep having the discussions with your agent too, because the agent needs to know that. And that's, while I'm thinking about it, something that people find very, very frustrating is what they perceive as being a lot of redundancy in the healthcare system. When you come into us, you will be asked on multiple occasions for your name and date of birth, because we want to make sure we're doing the right thing to the right person. You will also be asked on multiple occasions if you still want to be a do not resuscitate. It doesn't mean we think you're making a bad decision. It's our obligation to make sure we're following your wishes. And so please also prepare your families, and those of you in the room will already know this, but you will be asked. We're not saying that we disagree with your decision to be do not resuscitate. Nor are we saying that we disagree with your decision not to be do not resuscitate. It's our obligation to keep asking to make sure that there is nothing that has changed in your wishes moving forward.